today, both here in Rochester and all across the HCR footprint, so I want to thank you. My name is Chris Cimenti. I'm the Senior Director of Innovation and Education, and I'm here to kick off the event. We're actually be having 3 speakers today, myself, Dr. Jack McIntyre, who is our HCR Medical Director, or Jarvie, who is the leader of our telehealth program. So we're very happy to provide to you a relatively engaging and interesting topic. Talk about innovative strategies for managing anxiety in patients with COPD. Today is Dr. McIntyre's birthday, so I'm sure that we celebrate today. So Dr. McIntyre, happy birthday. Hope you're going to get it off to a really good start. How's that? Last night for you, Dr. McIntyre. And I made your cake this morning, too. Okay, so back at the basics. According to the RCP list, we have nurses, we have therapists, social worker, nutritionist, speech therapists, and several folks from our health home. So I want to get everybody on the same page with actually what COPD is. C stands for chronic obstructive pulmonary disease. Chronic means it's long-standing, it's not going to get better. Oftentimes chronic disease is worsened over time. Obstructive means that the airflow out of the lungs is restricted, relating to your lungs and bronchial tree, and I know what a disease is. Inflammatory lung disease, and we'll show you that here in a minute about the inflammation that occurs with the disease. COPD affects about 24 million here in the U.S. alone, so it's a widespread condition. I'm sure you have either treated patients or seen patients with this disease. And again, it obstructs blood flow in and out of the lungs. And what we can think about with COPD is there's also loss of gas exchange, meaning that even when our patients get in and out of their lungs, they actually receive less perfusion of oxygen to their bloodstream, and I'll show you why in a minute. Talk about the causes of COPD. It's long-term exposure to irritants. Can anybody leading cause of COPD is here in the U.S.? Anybody? Yes. Several people here in the room. Cigarette smoking actually causes about 80–90% of all cases. So it is obviously the leading cause by far. Others are secondhand smoke related to someone else that may be smoking. Things like chemical fumes related to industry or poor ventilated homes, and a small percentage of patients that have COPD related to a genetic disorder as well. So there's that occur in the respiratory system that contribute to COPD. Does anybody want to take a guess at what one or two of those conditions may be? I just heard emphysema, that's correct. Anybody have a guess? Anybody on the phone?
Bronchitis.
Excellent. So the two contribute are chronic bronchitis, which is an inflammation of the lining of the bronchial tubes, and those are the air passages that go in and out of the lungs. And we'll show a diagram here in a minute. And emphysema is where the alveoli, which are small little air-filled sacs that are that essentially make up your lungs, they lose their elasticity, they lose their surface area, and we're going to show you what that means here in a minute. But think of when you take in a breath, those alveoli expand like you're blowing into a balloon, and when you exhale, they contract and they help push air back out of the lungs. So with emphysema, you become rigid and less elastic, so it's harder to get air in and out of the lungs and get air in touch with your blood, which exchanges the oxygen and the carbon dioxide. So this bronchitis looks like, you can see here in the diagram of the lungs, the bronchial tree is what comes from your mouth and then comes down and spreads out into this system of like a airway tree, and then connects with your alveoli at the very terminal end. And on the side of the diagram, you see what a healthy bronchial tube looks like. right? You can push the air in and out of there. With chronic bronchitis, you get a lot of inflammation and mucus that pushes into the airway. That air gets narrowed, and you can see it's going to be harder to push air in and out of that tube that you're looking at right there. Like I talked about before, these alveoli, they almost look like grapes on a vine. When you look at a real tight bunch of grapes, think of that, and those grapes is these air-filled sacs, okay? And like I said before, those air-filled sacs open and contract like you're blowing up a balloon and then letting air out of a balloon. With emphysema, the walls of those alveoli become stiff and rigid, and they don't expand and contract. So you're actually losing the ability to push air in and out, and losing surface area, meaning that the alveoli are all bunched and twisted and compacted together, and they expand within. The oxygen can be exchanged more easily. With emphysema, that is less likely to occur. So the alveoli, again, lose surface area. There's less area where the oxygen can exchange. So in a normal, healthy adult, the analogy would be that you have a surface area associated with a tennis court. Think if you laid all of your air-filled sacs out and spread them out, you'd actually be able to cover a tennis court. In a patient with advanced COPD, maybe the surface area of a ping pong table. Okay, again, less ability to actually exchange oxygen and perfuse your body. Common symptoms associated with COPD are breathlessness, obviously, for the reasons we just talked about. Because it's an inflammatory disease, there's a lot of mucus production very often. If you get mucus production, it's an irritant in your airway. And the body wants to cough and bring that up and expel it from your airway, which is an audible sound of air moving in and out of the respiratory system, okay? If you're all sitting here very nice and quietly, you don't hear each other breathing, right? Okay, but with patients with COPD, you get abnormal breath sounds that sometimes you actually can hear. Chest. Can anyone tell me what cyanosis is? So turning, which is associated with less oxygen perfusion, right? So if you take oxygen saturation values with your patients that are cyanotic will actually have fingertips that are to be blue or purple because they're not getting enough oxygen into their body. And with that, I think it's to expect that they're going to loss of energy, right? They're not getting enough oxygen to their body, and they're taking up a lot of energy and effort to actually breathe. Why we're anxiety, right? So if you can't breathe and you can't get enough oxygen and you're tired and you're gasping for breath, it's going to, and Dr. McIntyre is going to talk a lot today about that with us. So quiz number one, you all should have a little quiz sheet with you. You pull that out. Just check your learned knowledge so far. Two primary lung disease processes that contribute to COPD. And emphysema. I'm going to pass before you leave, I promise you that. Back on 2015. So this is information relating to our patients here at HCR across the footprint in 2015. Can you guess the two primary diagnoses that topped our hospital readmission rate in 2015? What are the two diagnoses? See, right? That's why we're here today. And the other I just heard is heart failure. Any surprise to any of you that are treating patients in the field actively, right? These are very complex and challenging conditions to manage. So these are 2015 data by month, the COPD, and the 30-day ACH rate relates to how many of our patients with that diagnosis went back to the hospital within a period of 30 days. So you can see this changes significantly from month to month. January, August, and December are the highest months by far. You can see those stand out, right? And a great month in September, where only 10% of our patients with COPD went back to the hospital in 30 days. The overall average here is 24.8%, or about 5%. So 1 in 4 of our patients went back to the hospital in 30 days with a diagnosis of COPD in 2015. Compare that national average. Now, this is home care data. I won't go through all this data, but actually information that was published in one of our home care publications in 2014 through 2015, 23% of the nation's patients with COPD that were enrolled in home care went back to the hospital in 30 days. 2 percentage points higher than what would be considered the standard. So let me see astronomical numbers. 1 in 4 patients, 1 million seniors, $26 billion annually is associated with hospital admission in a 30-day period. Those astronomical numbers, right? Think about $26 billion associated with our Medicare beneficiaries bouncing back to the hospital in 30 days. ACH is the Centers for Medicare and Medicaid. All of our government leaders are very, very interested in reducing this cost. Any of these readmissions are what we consider avoidable. And we're going to talk today about strategies to help with that. So our goal at HCR is obviously to reduce hospital readmissions, right? Reasons. So please, symptoms. Quiz question number 2 related to COPD. Go ahead and do it out. Restlessness, right? Lack of energy. I was hoping, Jessica, thank you. Obviously. Okay. Help patients that have COPD control their stress and anxiety associated with the disease. McIntyre and Laura Jarvie are going to help do for you today. I want to break this cycle. So when patients have shortness of breath, they become anxious, then they have increased heart rate and more shortness of breath. They feel more on their shortness of breath, and this cycle continues. And you're going to see the diagram a couple different times through our presentation. We want you to break into this cycle of patients that experience anxiety with COPD. So we must expect ourselves to be better than our competition, right? We want to be better than the national benchmark, and we have to be better than our competitors because we want patients to come to HCR because we are the best at taking care of our patients, right, compared to other home care agencies. Our hospital partners demand that we're better, okay? There are significant financial penalties that the hospitals receive if patients bounce back to the hospital in that 30-day time period, and COPD is one of those diagnoses. So they're looking to partner with the home care agencies that have lower hospital readmission rates. Equip you with good strategies to help you with this anxiety issue. Patients expect and deserve the best from HCR. So we'll phone over to Dr. Jack McIntyre.
Chris, and I appreciate very much all of you being here for my birthday party this morning. That was kind of you to turn out. Well, thank you very, very much. I know I got to get that with birthdays, as some of you are familiar with, you know, as they go on, you kind of wish that they weren't going on quite as quickly as they are. But interesting conversation yesterday with my 6-year-old grandson. We go out to lunch, he and I, on Wednesdays. He gets home early from kindergarten. We go out to lunch. So we're driving along. I say to him, I said, you know, Charlie, I'm looking forward to the time when you're driving and I go out with you. And there's this pause for a minute, and then he says, well, Mac, they call me Mac. He says, Mac, you may hear. So I said, what do you mean by that? He said, you may be gone. Gone where? He says, "God heaven." I said, "Well, I like the destination, but I'm not sure that I'm keen about the time frame that you're suggesting here." But anyway, it's a delight to be here, and I appreciate very much. And actually, much of what I want to say, Chris has said either briefly or put a little underlining to it, which is great. So I'll try to underline some of the things that Chris said, and then we'll hear from Laura, and then we'll have time for all of us to discuss it together. Because we're really interested today is making sure that each of you have a good understanding of the interaction between COPD and anxiety, and also feel comfortable in terms of interventions that may be helpful for our patients. The avoiding hospitalization is, as Chris said, is very, very important, and obviously a tremendous financial drain. And also, it's one of the goals of HCR is to decrease the hospitalization rate. But not just the finances that's important. It's also in terms of the impact on patients, because as you know, going to the hospital incurs a certain amount of risk for patients. And patients with a C. diff and everything else that happens in the hospital, it's not a danger-free place to be. So we want to avoid that. We want to keep our patients safe and comfortable. And obviously, they're a lot more comfortable in their own home than they are in the hospital. Okay, so this is a theme that you've heard about already, and we'll be coming back to repeatedly over the next hour. Namely, that with the COPD, there's a shortness of breath, and with the shortness of breath, invariably, a patient with COPD is feeling anxious about what's happening. Am I getting worse? Does this mean that I'm going to have to go to the hospital, my medicines aren't going to work, et cetera? And that just leads to increased shortness of breath and anxiety. And then after this struggle keeps on going on for a while, patients start getting fatigued, and that also contributes to the difficulty breathing. Now, anxiety, and also we're going to talk about depression because the two are often related. And with depression and anxiety, but there's three ways that anxiety can manifest itself. First is anxiety disorders themselves. So some patients with COPD have another illness, have a comorbid condition, an anxiety disorder. Others have primarily a depressive disorder, but with depression, about 80% of folks who are depressed also have anxiety symptoms. Another way the anxiety shows up. And finally, of course, there are those that have both anxiety and depression, and that number is also significant. Now, looking quickly at some of the studies that have been done in terms of COPD, first of all, we're going to look at depression. 1 in 4 patients with COPD have a depressive disorder. 1 in 4, that's 25%. And that compares to about half that number, about 12% of individuals who do not have COPD have depression. So depression is a common disorder, but it's as common in those that have COPD. Looking at COPD with depression, folks who have depression are 77% more likely to have a hospitalization related to their COPD. Those who are not depressed, 77% more likely. So obviously a very significant number that we have to pay attention to. Also, 48% are more likely to use the emergency room compared to those who have COPD without depression. Okay, so the message here is clear that with depression, COPD, you're more likely to use the acute care services, and that's why we have to attend to depression. Now, about anxiety, the same kind of numbers crop up. This is a study from 2013 which showed that you have anxiety and COPD in 41% of patients. It's a combined condition. With COPD are 10 times more likely, 10 times more likely to have a panic attacks compared to those without COPD. 10 times, so very significant. 85% of COPD patients have depression and or anxiety. So more than half of your patients that have COPD have depression or anxiety as prominent symptoms. So to pay attention to the depression and the anxiety. Now, today, we're focusing mainly on the anxiety piece of this. As I say, it goes along with the depression, but we're focusing mainly on the anxiety piece. For this part of what we've talked about so far. Okay, so anxiety disorders and depression frequently and significantly increase the use of acute services. Okay. Number two, clearly anxiety and depressive disorders should be identified, and then three, they should be treated. Okay. So these common correlates of COPD have to be identified and treated. We're going to talk a little bit about how to increase the identification and also how to improve the treatment. Now, this is a scale. It looks more complicated than it really is. It's called GAD-7, a scale which is basically filled out by the patient. And once the patient fills it out, it takes about 30 seconds for a clinician to then look at this and to see whether or not there's some significant findings here. Okay, so and look at these 7 questions, and these are the 7 what we might call the psychological symptoms of anxiety. Number 1, and all these questions are in the past 2 weeks. How often have you been bothered by this? Feeling nervous, anxious, or on edge? Number 2, not able to stop or control worrying. Number 3, worrying too much about different things. Number 4, trouble relaxing. Number 5, so restless that it's hard to sit still. Number 6, becoming easily annoyed or irritable. And then feeling afraid as if something awful might happen. Okay, so there are 7 sort of psychological or behavioral issues that folks who have significant anxiety will manifest. And then patients check several days, over half the days, or nearly every day, and then you just total up the result. And if it's more than 10, if it comes out more than 10, that's a significant anxiety symptoms. So now, you don't necessarily have to do this with each patient. It can be helpful if you're worrying about it. If you have this scale, have the patient fill it out. The important thing is to recognize that these are the symptoms. So when you're talking to your patients, you can ask, have you been feeling so in the last couple of weeks? You've been so restless that it's hard to sit still. What do you find yourself thinking about? Worrying about some matters, many matters. Do you think that something awful is going to happen? Those are questions that you can think about or see if the patient manifests that in other ways, sort of conveys that to you when you're actually asking those particular questions. Okay, here the one for depression also. This is the so-called PHQ-9, and it's a similar type of a scale. In the last 2 weeks, how often have you been feeling, these symptoms? And we're not going to spend a lot of time on it because we're focusing mainly on anxiety today. This kind of thing that the symptoms of depression, and you see how often patients are bothered by this. They fill it out typically, and when they come off office, when patients come, I have them fill this out, and then just take a quick look at it and see what we can learn from it about the scoring. Okay, what I want to do is to just have your input for the next couple of minutes and describe patients with what you think are anxiety symptoms. What do you hear from patients that convey to you that they're anxious? Just any thoughts at all? Think about patients and ones that you think. Okay. So, shortness of breath. So good. Back to that in just a minute. Okay. Other symptoms that patients.
They ask the same question over and over and over.
Again?
They repeat the question frequently.
Okay, so some asking again about the same thing, and it may not be just a memory problem. It may be trouble that they have in terms of focusing or listening to what you're saying. They're distracted. difficulty in relaxing generally or sleeping. Is that a wave?
Please hold the microphone closer to your mouth. It's hard to hear.
Oh, thank you very much. Appreciate that. Yeah, all right. Other things, Chris. What do you mean by irrational behavior, Chris? Yeah, to say things that don't really make sense in terms of what it is that you're talking about. Sometimes that can be that they're distracted and they have other thoughts that are sort of popping up in their head and they're anxious about, and so you hear things and say, oh, that doesn't fit to what we're saying. There are causes of that too, but anxiety can be one of them. Yeah. Focus on negative issues and rather than in terms of the input that you're trying to give them. Yeah. Okay, so the breathing changes, and that's a very good one. We'll come to that in just a minute. Yeah. Okay, so these are all very, very good examples of things that you see day to day with patients that may suggest that what they're really struggling with is some significant anxiety symptoms. Now, the physical symptoms of anxiety. We talked before about some of the psychological symptoms, right, in terms of they can't sit still and rest of some of the behavioral stuff. But these are some of the physical symptoms that patients experience. Shortness of breath, so they're breathing fast, palpitations, they feel like their heart is thumping, temperatures, they feel either real cold or real hot, sometimes very quickly another, lightheadedness, weakness, and these are all classic physical symptoms of anxiety, okay? Now, what do you notice about this in terms of talking about? The overlap between this and what Chris was talking about in terms of the physical symptoms of COPD. Okay, obviously shortness of breath, okay, the sweating, the lightheadedness, the weakness, all these you see with the COPD. So it gets confusing for patients, and it also gets confusing for us, right, clinicians, because you hear these symptoms, and it may be clear at first, are we talking about the COPD getting worse, or are we talking about anxiety symptoms being more prominent? Okay. Okay, here's a question. Patient with COPD, how many more times more likely to have a panic disorder, panic attacks compared to controls? Now, about the interaction of COPD and anxiety. Okay, what you have here is what we call the circle of anxiety. Very classic, what happens in terms of anxiety symptoms. So the individual this is hard to control. Becomes stressed, right? Gets a little short of breath, then is a little more anxious, breathes faster, then the breathing muscles begin to tire, and what happens is you get some even secondary muscles of respiration get involved. Short breath increases, the anxiety increases, breathing becomes more rapid, breathing muscles tire even more, and then it continues to spiral until you have a full-blown panic attack. Okay, so classic anxiety symptoms: the shortness of breath, difficulty breathing, palpitations, sweating, and a sense of dread. Okay, now this is this slide with COPD. This is purely anxiety. Okay, now as we said, the problem is that this overlaps with COPD, so it makes it tough for us as clinicians to figure out what are we really seeing. So this is what we have to try to figure out in terms of this anxiety. This is COPD. Often it's a combination of the two. What can we do to decrease the anxiety part of it so the patient doesn't become more and more upset about the COPD worsening and end up in the emergency room or being hospitalized for what really was an anxiety attack, increasing their anxiety symptoms. Okay, so part of what needs to happen is that there needs to be an assessment. Okay, so you're seeing the patient and you have to ask yourself and the patient, how long has been increased difficulty breathing? Now, if the patient says, well, actually over the last several days, I've noticed that I've had some increased difficulty in breathing. That may be a very good clue that this may not be primarily anxiety. Okay, maybe something that's changing in terms of either bronchitis or something else that's causing the breathing to become more difficult. So anxiety episodes don't generally stretch over several days continuously. So if the patient reports that they're getting more difficult each day, it may actually be the COPD is worsening. Have you taken your medication, your inhaler, and when was the last time that you took it? It's amazing at times that patients have some difficulty in terms of breathing and don't use their inhaler, especially the rescue inhaler that they have in terms of when they feel especially short of breath. Okay, so you want to remind them about that and to check that out. And also, Chris mentioned in terms of the skin color. Is there some darkening of the skin color and nails? What about their pulse? Is it increased significantly now, which we said can also, of course, occur with the anxiety. O2 saturation, that's a wonderful tool, and if you have an oximeter, if the patient has an oximeter, that's a great tool in terms of how much difficulty are getting into physically because of the shortness of breath. If they have an O2 saturation of 93, 94, well, there's less worry that there's going to be immediate problem in terms of their breathing because they are getting sufficient saturation in terms of their hemoglobin that that it's not going to be an immediate danger in terms of their COPD. If you evaluate the patient and you think, well, the color of the nails, they're having more difficulty over the last several days, and the oximeter suggests that they really are having more, getting into the 80s in terms of O2 saturation, then you need to escalate what happened. And for those who are not nurses, calling the nurse that's involved with the patient is certainly a very appropriate next step. And for the nurses, or if that step has happened already, then consider calling the doctor's office. And we're going to talk a little bit later about what that means and what the best way to, what's the best thing to do when you do call a doctor's office. What you avoid is the, if it's sounds like a bit of a puzzle to the physician or to the office staff, then, have them go to the emergency room is a quick, easy solution. But it may not be the best solution. So we think it's mainly anxiety. You assess the patient, say, well, I don't really think that this is a worsening of COPD. I think they're very anxious at this point. So what do you do? Well, first thing is that, you assure them as well as yourself, because we get anxious, right? You're somebody who's having trouble breathing. As clinicians, we get anxious. Something, bad's happening here, and I don't want to miss something. So I do something quickly. And, you want to reassure yourself as well as the patient that, it's going to be okay. A few things that's going to help in terms of decreasing your anxiety, helping you relax and make your breathing easier. Okay. Now, sometimes this can be done on the phone. If you're actually there, often that doesn't occur like that, but if you're there when this patient is getting more anxious, then it's a great opportunity to do something very directly. Members can be very supportive and should be included in terms of discussion about how to relax when you start getting more anxious. Now, some families may not be real helpful and can actually matters worse. And they can, immediately want to jump on, let's go to the emergency room, oh, this is bad, and I can see this coming, and blah, blah. But, maybe that helping them to recognize that it may not be the best thing to go to the emergency room can be useful also. And all of this, has to be done over time in terms of the education of both the patient and the family member in terms of what's the best next step. Okay, and then sometimes talking to the patient about what you previously have talked to them about, namely their illness and the COPD, and how the anxiety can make it, appear worse. And if we settle down the anxiety, you're going to be able to breathe better. All can be very helpful. Helping the patient focus on other matters can be very important. So what we talked about before in your examples that you used in terms of the patient is distracted, well, this is a positive distraction away from their symptoms. It'd be something that is fits for that particular patient, because some activities or even some discussions aren't going to be helpful for patients. But if it's something they're interested in, et cetera, it can be very helpful. What we commonly use is that you ask the person, think about a place where you'd like to be. Right? And sometimes doing that imaging of a place that they'd like to be helps in terms of decreasing their anxiety. Sometimes doing something behaviorally can be helpful. For example, here is tap your right knee 10 times and tap your left knee 10 times. When you do that, especially if it's a new kind of little task for you, when you do that, you can't focus as much on the anxiety or even on your breathing. Okay, you're focused on something else, and focusing on something else helps to decrease the anxiety and decrease the rapid breathing. This is where the rapid breathing is being fueled by the anxiety. If it's being fueled by the COPD, getting significantly worse, and there's a real tightness in the chest, they're not going to be able to breathe easier as a result of tapping their knee. For some folks, if they're having a difficult time in terms of some either at home or in their life, making them more anxious, it could be that increasing phone contacts or increasing visits can be helpful. For long term, in terms of helping patients learn some of these techniques so they can use them over time, there's a very nice program called Step by Step. Are already familiar with it, and there's some copies of it available at the back. Step by Step is a program that is for patients, taking one step at a time, and various things that they do that helps them to learn about their anxiety and how to decrease it. And it's part of this little self-help manual about COPD. They're available at all the sites, and if you wanted to look at this, it's actually designed for patients to use step by step. But you can learn a lot from it, and you can incorporate some of the things that it says in here into your work with patients without them filling out this step by step. And two things that they talk about in there in terms of COPD is hydration and exercise. So a moderate amount of exercise is very helpful. And hydration is very important. Dehydration is a frequent precipitant of increased problems with COPD, as it is with other conditions also, but especially with COPD. Also, the patient can practice some relaxation techniques. So talk to them about, when you start feeling anxious, what you might do is X, Y, Z. Whether you focus on something else, distract yourself, do some these little physical things that we talked about, whether it be tapping your knee or something else. So patients can learn about relaxation, and they can sort of control the symptoms themselves, which is obviously the best outcome when they learn techniques that they can use that helps to decrease anxiety. Then there's a technique that's called cognitive restructuring, and we're going to come to that in just a minute. Patients who have increased social contacts and increased engagement with something will have less trouble in terms of the anxiety symptoms mounting. Now, for some people, we know that, you know, in the North Country or other places, or they're fairly isolated, this may be difficult, but thinking about ways to increase their contacts can be very helpful. There's a wonderful little book called From Nervous Suffering that some of you are interested in just to read for yourselves. And for some patients, I have found it very helpful. Dr. Weeks was a woman, general practitioner in Australia, and she wrote this book about anxiety, and it's tremendous. It talks about, very often patients read it and say, hey, she's talking about me. That's exactly what I feel. And this can be very, very helpful tool also, Peace from Nervous Suffering. If you want to get a copy of it, it's not a print actually, but it's on Amazon. You can get a copy for like $4 or something. And others have them too. Okay, cognitive restructuring. Basically what it is to change the mindset. That's what it means, cognitive restructuring. So for the patient, very often they start having trouble breathing. Something bad's going to happen. That's the thought that they have, or I know what this is going to lead to, et cetera. So what you want to do is to restructure that. So instead of, you know, something bad is going to happen, they think, this is going to pass. I've been through this, you know, 20 times, and it always works out. So to change the mindset in terms of how they're thinking about their individual symptoms, okay? And it's amazing how helpful this can be, because patients invariably will fall back to the whatever the theme is that they use. And it's patients in terms of the theme, and you can ask them, you know, what do you really think of when you start having shortness of breath? And they'll tell you. And very often it's something like this, you know, something bad is going to happen. So what we want patients to think is, I've been through this before, and it's going to be okay. Okay? These are general techniques for folks with anxiety disorders generally. You don't have to have COPD, obviously. This is generally what's helpful for folks with anxiety disorders. I say learn to do this. You really are gaining mastery over their anxiety symptoms. Weeks in her book talks about a number of different sort of techniques like this, but basically they all come down to the same thing in terms of shifting the set from a bad outcome to a good outcome. Okay, there are some medications that are very helpful for anxiety symptoms. First is caffeine is a bad medication for folks who have anxiety symptoms. Caffeine, and the reason that we drink coffee, right, is because it increases, it sort of gets you moving in the morning, et cetera. It's a stimulant in that regard, and it's a psychic stimulant. But folks with anxiety symptoms don't need a stimulant. Okay, caffeine makes anxiety disorders worse. Decaffeinated or no coffee, teas, etc. Okay, the most common antidepressants used today are what we call the SSRIs, right? Selective serotonin reuptake inhibitors, and they're all the common ones that you know, Prozac, Zoloft, Celexa, Paxil, Lexapro. These are all SSRIs. Now, the good thing is, of course, many patients, as I said, with anxiety also have depression, but the thing is that these antidepressants are first-line treatment for anxiety disorders. They've been proved to be very effective, even with no depression, for anxiety disorders. Okay, SSRIs are very, very helpful for folks with anxiety disorders. Then the number of other antidepressants, please. Uh-huh. Yeah, so generally the SSRIs are effective within a couple of weeks for the depression, and you're suggesting, great question, it may even be sooner for the anxiety symptoms. So, you know, it's not going to be, it's not the kind of medication, we'll get to the benzodiazepines in a minute, it's not the kind of medication that you take now and your anxiety decreases, because it depends on a blood level that does have to be built up over time, but not several weeks. I'd say a couple of weeks. What we're thinking about here is for folks who have common bouts of anxiety, you know, on an SSRI can be helpful in terms of, you know, decreasing that sort of baseline level of anxiety. Okay, and there's other antidepressants that also are helpful, certainly for depression, and maybe somewhat for anxiety also, but not quite as much as the SSRIs. Okay? The group of medicines that we're familiar with, right? The benzodiazepines. Okay? It used to be Valium and Librium, and now it's Xanax and Ativan, lorazepam, alprazolam, and these medications do decrease anxiety. Okay. The problem is that they're also addicting, and folks will often begin to escalate the amount that they're using. There's also a concern that, well, they may actually decrease folks' ability to breathe effectively. And that's not the case clinically, most clinicians feel now. A lot of research has been done on this, and in the doses that we're talking about, regular low dose, if you were to use an excessive amount of benzos, then it can begin to interfere with cause some respiratory depression. But in the low doses, it's generally safe. But you want to be careful about not over pushing patients to take these benzos, because then, as I say, they'll get more and more addicted to them, and it gets much more and more of a problem. And for folks that have an addiction problem to begin with, they're a bad idea. So we try to stay away from them and anybody who has a history of addiction. Two other medicines that are helpful. One is Buspar, buspirone, which is an anxiolytic. It does decrease anxiety. It's not sedating, and it's not addicting. So that's a good medication. It's probably a little bit less effective in terms of decreasing the anxiety than the benzos, which is why it hasn't sort of taken over. But for those who find it helpful, it's a great drug to use. And then another one is Neurontin or gabapentin, which has been used in a variety of cases. And for some patients, again, it's very helpful in terms of decreasing anxiety. Okay, the key here that the three of us want to emphasize today is that communication, as the case, is really the key element. Communication in terms of you and the patient, you and family members, in terms of, family members and patients should know that what the anxiety does in terms of making COPD, appear worse and increasing the symptoms, et cetera, and decreasing anxiety is going to be a help in terms of their COPD. They know that. And communication among the team members is crucial also. So you're a physical therapist, and that you and the nurse involved in the case, are on the same page in terms of the extent anxiety is a significant issue here, and what both of you are going to be focusing on what the treatment plan will be in terms of paying special attention to anxiety symptoms. Okay, the next quiz question. Which of the following are physical symptoms of anxiety? Any? One of them would be correct because the answer is indeed 5. All of these are physical symptoms of anxiety. Okay? So somebody who has COPD is sweating and they're breathing fast does not mean that their COPD is getting worse. It may mean that their anxiety is getting worse. Thank you very, very much. Yes. A very good point, and it is amazing the number of meds that patients are on. And you can spend a lot of time just trying to stay on top of what medications they're on, and obviously some are much more important in terms of potential negative effects as well as positive. Louise has indicated that HCR has a relationship with St. John's, with the St. John Fisher Pharmacy Program, and they're available to help us in terms of clinicians who have questions about medications, et cetera. And we may also talk to them about, it hasn't been done already, distributing some information that sort of a little more detail into some of these meds than we were able to cover here this morning. So, okay.
We can't hear what the people in the room are saying out in the field. Can you repeat the good points, please?
Yes, that's Chris just pointed that out to me, and the last question was from Louise Werner, and her point was that our relationship with St. John Fisher School of Pharmacy allows us to use them as a resource for questions about medication, et cetera. And folks that have particular questions, Christina Fredericks is the point person. If we get questions to her, she can get back to us with the information from St. John Fisher. And we're also going to explore with them if they have some nice handouts that might be helpful for clinicians generally. We will get them and distribute them. And I apologize for not repeating the question earlier. Laura will definitely repeat questions. Please. Yeah, the question. The question is data about either race or in terms of COPD. The gender is a little easier than the race question, but the gender, males are more common with COPD in part because of the amount of the smoking history, generally heavier smokers, even though obviously women are a significant number, unfortunately, are smokers also. But males are more common in terms of COPD. In terms of the race issue, it also varies depending on the setting and the environment. And we'll get some more specific information for you and for everybody else about that. Thanks.
I'm going to talk with you. I'm going to talk with you guys today about some interventions that we have here at HCR to help us, exercise these best practice interventions for our COPD patients. Some of them have been in existence for a while, and we've given them a bit of a facelift. And other is some new material that I'm going to go over with you today. So our devices, as part of our plan of care, we have a COPD pathway that can be selected when we're doing that episode planning. We use it to include some anxiety education pieces for our patients and management for anxiety. It's expanded, so therapy now has its own COPD pathway. Chris put together some really good interventions for that. It's specific education and best practice interventions specifically for COPD. So I know there's a respiratory pathway as well, but the COPD pathway really drives into the disease a little bit more. It's for easier documentation. So I worked in the field for a long time. I get it. You're busy. We want to just be able to get everything as quickly and as efficiently as possible. So by using the pathway, you can select the interventions that you've provided and document against your goals right in the visit. And the goal is to get us to use it on all the COPD patients. So we took a look at how often are we using our existing pathway, and we have some real opportunity for improvement there. I think the respiratory one comes up first, and maybe that's why that's being selected more often. But I'm really going to encourage you guys to look at that COPD pathway and incorporate that into your plan of care for these patients. So the zone thing, this is not new for anybody. We did state this as well to include some anxiety symptoms in the yellow zone for caution. This is talking about what Dr. McIntyre talked about, what Chris talked about. COPD and anxiety are both fear-driven diseases, right? So patients get scared, they go to the emergency room. One day, most of them are enough that they're going to be admitted just because that's their baseline. So if we can teach them self-management techniques at home to identify and have a personal action plan, we're going to help reduce those readmissions. It gives them who to call at what point, and certainly individualize this. So over here, it has us for their quick relief medicine. So maybe we want to put their Xanax in there, or their albuterol, or whatever is appropriate for their patient. We have the COPD, sufficient self-management, stress and anxiety, helplessness and anxiety. So we talked about what's anxiety versus what's COPD. This helps the patient understand the difference between the two and help them individualize the treatment that they take for that. It certainly provides the education that you've already provided in the visit. It helps reinforce that. So, we spend a lot of time talking and educating in the home and leave maybe not to come back for 3 or 4 days. This allows the patient to kind of have a refresher when we're not there. It validates their feelings. So a lot of patients don't talk about anxiety. Sometimes they're even offended when you mention, I think this might be anxiety. No, it's not. I can't breathe, right? It's a defense mechanism. But by saying, it's okay. Most patients with COPD experience anxiety. That allows them to feel safe to discuss feelings with you and also seek appropriate treatment for that. And a relaxation test for them. So this is a really helpful tool. I'm excited to get this in use. So you guys all know this girl, right? So of course I'm going to talk about telehealth. Telehealth is great for COPD. Readmission rate for 2015, we did some increase in readmissions with the use of telehealth. So this is comparing telehealth patients, non-telehealth patients. Telehealth is a tough egg to crack, COPD is a tough egg to crack. We really want to make sure we're keeping clinical contact with these people. And increasing the clinical contact with telehealth, we're able to keep them at home where they belong. So we have done with increasing telehealth use on the COPD population, looking at about 3% in February, so we still have some room to go. We want to identify all COPD patients and see if they're appropriate. I realize not everybody may be physically appropriate or have an appropriate home environment, but I think that other 60%, we have some room to grow there. We do. I'm not going to exceed our target because we're pretty low here, but we want to keep going. We can really, we got our new target, 100%. An example of a COPD call.
Hello? Barbara? Carla, I'm one of the nurses in the telehealth office at HCR.
Hi, honey.
I had a telehealth transmission you sent through a little while ago. You indicated some changes in your symptoms that I would like to talk about today. What's going on?
I've been up all night. I'm having a real bad day today with my breathing. I think I might have to go to the emergency room.
Before you do that, can you tell me more about your symptoms? Have you had any fever or chills?
No.
Had any changes in the amount, color, or consistency of your sputum?
I just can't seem to catch my breath today.
I can hear that you are short of breath today. I'm sorry you're not feeling well. What have you done to try and help your breathing?
I cut up my oxygen. It was only at 2. I got up to 3. It didn't really help that much, though. I get so winded. It's like I can't get any air.
It's very scary when you can't breathe. But I can see from your vital signs that your body is getting enough oxygen. Let's keep that oxygen at 2 liters, just like the doctor ordered.
Okay.
With COPD, which is your diagnoses, the problem is not always getting oxygen in. The problem is getting the old air out. There are breathing techniques we can use to help slow things down and help get you back in control.
You're going to teach me how to breathe. I've been doing that for 79 years.
I know. Listen, are you sitting down, Barbara?
Yeah, I'm in my recliner chair. A lazy boy.
Oh, great. Love them. But the first thing I'd like you to do is to put your legs down and sit up nice and tall.
All right.
Now, what I'd like you to do is I'd like you to close your eyes. And then I'd like you to take a nice, deep, slow breath in through your nose. We're using that oxygen that you've got going.
All right.
Then I'd like you to hold this deep breath while you picture the oxygen traveling all the way down to your toes. Then, the most important part, I want you to slowly exhale with your lips pursed. And then you are keeping the flame of a candle. You're exhaling until you feel like your lungs are empty. And this gets all the old air out.
Okay.
All right. How are you feeling now?
A little bit better. My chest is still tight, but I feel better.
All right. These breathing exercises can help you to get back control and get rid of the extra carbon dioxide, making room for fresh oxygen. It's important for you to understand when you get short of breath, anxiety makes you breathe faster and hyperventilate, which then makes this problem worse. So it's very important when you are having these episodes that you sit down and you do these breathing exercises. Understand?
Yeah, I get it.
All right.
I get scared when I'm short of breath. I get scared, so yeah, you're right. I breathe faster.
Absolutely. So it's important just to take a moment and to remind yourself, I got to remember how Carla taught me to breathe. Can you do that?
Yeah, well, I'll do that.
Right. I'm going to look at your medication list. Talk about the medications you have for your breathing.
Mm-hmm.
Have you used your inhalers at all today?
No, I haven't.
All right. I'd like you to go ahead and have breakfast and take your medicine. I'm going to let your nurse know that you were having a bad day today, and I'll back later to check on you. If things get worse or you have any other concerns that come up, I'd like you to call me. Do you have a magnet with the phone number to reach HCR?
Yes, it's right there in my refrigerator. The nurse put it there for me.
Perfect. All right. And you know that you can call HCR 24 hours a day because there's always a nurse available to speak with you, right?
Yes, thank you, honey. I appreciate your help.
You're welcome, Barbara. I'll speak with you soon.
Okay, thank you.
All right. Bye-bye.
Bye-bye.
Okay, we heard Carla there, Barbara and her lazy boy. And so by using the information transmitted over telehealth readings, Carla was able to identify this patient is in trouble. She's one of the first patients that's contacted because she's indicated that she has some symptoms. Looking at this, we also know that physically she's not likely acute, right? Looking at her COPD process, getting enough oxygen, her heart rate isn't high to show that she's compensating. So this is probably something that we can talk through and work through using management techniques. So the way that telehealth works is that learning when the machine asks them some questions, answer yes or no. If a positive response to a symptom question, it's going to ask more questions to hone in on that symptom. Each of those symptoms is weighted to generate a symptom score. A higher score means that patient's more acute, so that lets us triage on patients that are transmitting. So address first, and we catch the patient in the teachable moment versus coming maybe at 3 o'clock in the afternoon that's already gotten worse or the patient's already gotten scared and gone to the emergency room. So when patients are on telehealth, we not want them to answer the questions when they're trained in the morning, but we encourage them, if they're having problems throughout the day, they can transmit again, and they can certainly call us. So, this allows us to act quickly rather than if Carla had scheduled a PRN visit for that nurse, that would have taken longer for them to get there than we act right then. Certainly, sometimes we need to use the PRNs in addition to our telephone interventions. The personal plan, so Carla telling the patient about using her breathing techniques and taking her medications, and that follow-up call that she's going to make later of you did this, you got through this, that's improving the patient's confidence, and time she'll know what to do. So I've run through most of this. If you noticed during that call, Carla was calm. She had a nice reassuring voice, made the patient feel safe. She validated the patient's feelings, which are important, and she supported the patient to doing things herself. You know, really put a patient in the driver's seat. We want this to be patient-driven, right? We want them to learn what to do and be active in their care rather than us everything for them. The closing, taking that deep breath, listening to Carla's voice, that really helps slow things down, helps with the anxiety. Looking, so what PRN medications are available? So this patient hadn't even taken her maintenance meds yet, so she's going to start with that. But maintenance will tell the patient, I want you to use your nebulizer. I'll call you back in 15 minutes. And if they're still not feeling better, then we might have to do something more emergent. Physiolytics are very important. And talk a little bit about when we call the provider, looking at SBAR. Interventions work, yes. If the interventions were successful, we really praise the patient. We don't want to take the credit that we walked you through this. We give them the credit. You did this, you can manage this, you got this. And we're here to support you if you have any questions. If you forget what to do, call us first, right? If things did not work, what do we get a nurse out there for a CP assessment? Do we notify the physician? When we are notifying the physician, we want to use SBAR technique for communication. If we said, Barbara, multi-disease is more out of breath today, she's been up all night, they're going to go, well, we can't see her, send her to the emergency room, right? Because that physician has some liability there. If I said, multi-disease has been feeling a little bit worse, we talked her through it, her oxygen saturation is looking okay. I think a lot of this is anxiety. I noticed she's not taking anything for anxiety. Can we get an appointment so she can discuss with the doctor her medications and evaluate if she needs a medication? That's realistic. So urgent care centers are everywhere. Our county has them. We spent a lot of time compiling a book of urgent care centers. So it is, something that the clinician in the home can't handle. The provider doesn't have any available spots to get the patient in. There's urgent care centers that we can utilize instead of the emergency room. It's a very appropriate thing. They can prescribe that prednisone, or they can give some antibiotics if it's some pneumonia starting. So utilize that. And follow-up piece is important to make sure symptoms don't recur. So increase nursing visit frequency, patients back later in the day to make sure they're still feeling well. So true at HCR with a diagnosis of COPD should be provided with a copy of the zone for COPD. True. Spanish. We have Spanish. What if they speak Russian? In Russian. So a patient should be getting a copy of that zone worksheet. And they're really one of your teaching tools during your visit. Here's one for you. In 2015, patients with COPD enrolled in telehealth monitoring had an overall 30-day readmission rate of versus the rate of 4% that did not have telehealth. 21 had a 3% reduction in admission, which actually brought us down lower than that benchmark average that Chris was talking about. So this is what we have available in virtually every area. So, use it. If you're a therapist, you have patients that are on, typically we want nursing involved, but if the nurse hasn't made the referral, that's something greater disciplinary communication. If you have questions about a referral, certainly give us a call. We can talk through it. Referral, hopefully everybody knows, fill out that telehealth referral coordination note that alerts us that the patient has to be set up. Utilize us. Back to Dr. McIntyre for some interactive dialogue, but does anybody have any questions before I do that? Okay. Mhm. Okay. Yep. So what other types of teaching tools do we have available for patients that, say, are more visual learners or maybe even illiterate patients or patients that don't understand over the phone? So absolutely. I mean, we have clinicians in the home. The breathing techniques piece is for managing that COPD because of the pathophysiology of the disease, and also with anxiety, the clinician can absolutely demonstrate. And actually, that's a great opportunity for teach back as well. So I'm going to show you how to do some pursed lip breathing techniques, and then the clinician can do it, and then you have the patient model that. So, show me what I taught you the last time. Have you been doing them? Or show me how you've been doing your pursed lip breathing techniques. And it's us the opportunity to provide reinforcement or also, help guide them if they're not doing them quite correctly. Kim. Mhm. Okay. Yep. So the question was for patients that are in our health home and not open to CHA services. I don't know. Certainly a CHA referral might be appropriate if they need disease education, depending on insurance and whatnot, but, talking with the patient, encouraging them to talk with their provider about having a nurse in short time, provide some of that education. And, not, then we can still have a dialogue with the physician of their experiencing those techniques. There's, things available online for, specific, but I don't know if that gets out of scope of practice to provide those. So I don't really know for your population. I'm sorry. If you wanted to look, I could certainly help point you in the direction, but.
No. Well, we have some time now to have more involvement of you all. And two things. One, obviously, additional specific questions that you might have. Also, this is a time you're thinking, well, all that's well and good. I hear what they're saying, but in the blah, blah, blah. So, this is a very appropriate time for the buts for us to dialogue together a little bit about it, because, as you know, you may very well learn more from folks sitting next to you than you from the three of us. So comments, questions, some real examples of difficult patients or difficult situations, and how to deal with it. Pass on so folks.
Can of worms. For a time, I've wondered why the doctors are not using the peak flow devices a lot more. Seems like by the time we start to see their signs actually being, resolved or changing in the vital signs, that we're chasing kind of the dog a little bit more. Where I've seen with the peak flows, as soon as those start to decrease, gives us a little bit more of an early warning. But the doctors never seem to really want to use that as a tool. And it seems like it's a much more effective way to monitor these patients. What's your take?
And I'm not sure of the full answer to it, but I think it may be one of those instances where talking to the staff, as Laura said, not just, should the patient go to the emergency room? I mean, but to talk about, what else might be of some help, and what about? So that kind of a dialogue, if we establish it with the, the primary care offices, I think that could be a significant help. Anybody have a response to that or anything they'd like to add?
Was that using the flow meter or like the the flow purpose we know about? I mean, my kids have, one of them had asthma, so we use that, which helps identify exacerbation. We're talking as therapists about using the positive expiratory pressure devices. Has that been in the research to be helpful with COPD?
If you use the device as a means of controlling it. Yeah, I'll answer to that in terms of if there's been any studies showing how effective that is in terms of patient, education and coping with it going forward. That's a great question. Out of the answer, Laura.
About patients in peak flow or with the other respiratory devices, I mean, you even have things like flutter valves and things along those lines. It may be appropriate as you have a difficult to manage patient. Chances are a primary care physician doesn't know what to do with neither. So recommending a pulmonology consult would be the way to go. So, saying, with all due respect, we've been having a lot of difficulty managing this patient. Do you think maybe they should see a pulmonologist? And that would be a little bit of a relief to the primary as well. So that's one option that we can certainly do. And the pulmonology will probably have more things like peak for trying some alternate, getting the results from the specialist.
Laura, and actually in thinking about preparing for this, I spoke to one of the pulmonologists over at the Unity system about what he finds helpful in terms of calls from nurses and others about individual patients and sort of what to do. And he said actually what we talked about here today, namely that the more information that he gets in terms of how the patient is actually doing in terms of the vital signs, obviously if there's an oximeter, but also changing the sputum color, frequency, et cetera, volume, that those kinds of that data coming to him, and I think the same primary care offices would be very helpful in terms of making the right decision, rather than just patient having more difficulty, what did I do? Okay.
Come from health home when we don't know that much about the clinical world that you guys live in. When, like, for example, I talked to a client that she called me hysterically crying, so I had to try to get her to calm down. It did end up going to the emergency room because she was in extreme pain, but I had to get her to calm down. Is there any other breathing techniques or tools or anything that besides the deep breath or what have you that we can have in our artillery, talk to people to bring them down?
So I have both here in Rochester and everyone that was distributed, the tool they have in front of you has specific strategies, and it's a good handout to provide to patients to help them self-manage their anxiety. Could add something, and then we do have to keep moving, but I want to make sure that the branches have an opportunity to ask a question if they have any.
Well, you kind of don't know what I was going to add. For those of us who are not nurses, and maybe even the nurses or are in non-clinical world, as an OT, a lot of times I focus on getting out of the sick mindset. So have you gotten dressed today? Have you showered? This time of year, why don't you go sit outside in the sun? Kind of all of those things that make someone not focus on, I'm sick, oh my gosh, I can't breathe. Getting back into more of a quality of life type of day. And so for OT, I spend a lot of time on what are the things you can do to distract yourself, get out of your pajamas, open the blinds up. It feeds into the anxiety and depression that then feeds into that if having these symptoms, I'm sick, I have to go back to the hospital.
So do we have from the branches that may want to ask a question to Dr. McIntyre? Okay, then to Carrie.
4x4 bar. Okay, you take a breathe in and count to 4 as you're doing that. Hold it, counting to 4, and then fire and counting to 4. Okay, so patients will focus on the expiration phase of it as well, which, as Laura pointed out, is key. So 4-4-4 is a typical way that's helpful for many folks.
Time. This is our last final question, Carrie.
That I really emphasize as an occupational therapist is the use of reflexercise, which is a very simple everyday activity technique that anybody can use, and it's targeting the autonomic nervous system and really from a brainstem level, just really calming the whole system down from an anxiety, pain. And it's simple and can pass it on. I'll give it to Chris, but it's really just assuming a position and really making the patient mindful of their body positioning and breathing together, and really targeting that brainstem and just lowering that heightened and really trying to calm that system down. Yeah, so it's it's the opposite of fight or flight. So when we're scared or we're anxious, we really get into that fighting position or fleeing position. So it's really in a position where you're outside of that fight or flight position. So hands open, arms open, neck exposed, away from that position, and then doing some of the deep breathing that, the tongue thrust forward so you can't clench the jaw. So it's really on how to handle those feelings of fear.
Would you come to a meeting and do a demo for us?
Great.
If I might just have a minute to wrap things up. Dr. McIntyre, do you have any few closing remarks at all? Okay, good. Okay, so I want to just wrap things up. Before you leave, make sure that you fill out your evaluation form, provide us your quiz, and if you did not sign in here in the back of the room, please make sure you do so on the way out. I want to just provide, as a closing remark, a sample. So what you heard in terms of what Laura played, that if you didn't know was a mock situation, although I think it sounded very authentic, very well, very good. But this is actually a real case that took place here at HCR earlier this year, so I wanted to go through it with you. This is a 74-year-old male living alone, using for ambulation. A hospital stay from January 13th to the 16th at United Memorial Hospital, that's in Batavia, New York, Genesee County. Primary COPD, which is what we've been talking about all morning. Past history was positive for heart failure, so we talked about earlier. 2 main diagnoses associated with a readmission, COPD and failure. This gentleman unfortunately has both. Osteoarthritis, so he has arthritis probably of the knees and hips, and I think also of the spine. So lumbago is low back pain, cervicalgia is neck pain. Diverticulosis is a condition of the intestines. Glaucoma, so he may have some visual problems associated with that. And guess what? Wouldn't you be just, right? He has anxiety. Okay, symptoms upon initial evaluation by the nurse. He increased lateral lower extremity edema. He's got swelling in his legs, likely due to the failure. Obviously, have shortness of breath associated with those two disease processes. He experienced a 10-pound weight gain, apnea, which means he gets short of breath when he lies down. So this is what pretty much brought him to the hospital. Upon to HR, he scored 12 on our hospital risk assessment, and 9 or higher indicates a high risk for emergent care or acute care hospitalization. No surprise from what you so far, right? So this is a list of his medications. We're not going to go through all of them. Ignore the fact that the Percocet is highlighted. That's not necessarily significant. I couldn't get rid of that in my screenshot. But he's on obviously a lot of different medications. And the option at the bottom, which is we're going to highlight here in the case example, is something that was added later. So you can see he was admitted to HCR on January 19th. added this on February 9th, and you'll see in the case example why. So back and forth in terms of a delay in his hospital stay. So you'll notice a discrepancy between when he left the hospital to when we started with him. And there was well-documented phone communication. He had actually gone to see his primary care physician in there, but note there was a slight delay. So out, the nurse ordered, obviously, nursing services, physical and occupational therapy, as well as social work. And one of the things that I liked when I looked at the record is we front-loaded that visit, meaning that we had 6 clinical contacts in week 1. So we were at the house pretty much every day. Somebody was monitoring his status or following up on his status. That's a really important element to keeping patients at the hospital because they're typically at highest risk during the first week when they're most acute. So we installed days later on 1/22. I think that's a pretty good turnaround time, when you say, Laura? Okay. So fast to February 9th, so we're 2 weeks ahead now, right? Medtronics is our telehealth, does our telehealth monitoring for us. So at 7:37, the bells and whistles go off. He uses nebulizer. He did not experience any relief. So Medtronics then escalated the phone call to our own telehealth department here at HCR. So Carla, who's here in the room, raise your hand, Carla. Is our telehealth coordinator. And then McMartin, who's also in our room, told me he would walk out if I pointed him out, but I just did. Our cardiac nurse coordinator in Genesee and Orleans County. The email volley that you're going to see go back and forth between Carla and Brian. So 9/21 emails Brian, said he's scared, sounds very short of breath. He wants a visit, and she says, I might call him and send him to the emergency room. Right? Brian says, okay, maybe something changed. 9:23, so 2 minutes later, you know what? Brian actually out at the house, out at the patient's house. 7:37, 9:21, 9:23, and the nurse is out. Perfect scenario, right? So at 9:55, Brian's in the home. He's in the patient's living room. Has possible panic attacks. Everything's okay. He's got 97% oxygen saturation. Lungs are clear after a smoker's cough. So, Carla then writes back 10:31. Thank you for seeing him. Can we get MD to order Ativan or something for him? So she's noticing the concern about the anxiety, right? I love Brian's response here. So 10:51, Carla, of course I called the physician, right? I received an order for buspirone, which is one of the medications that Dr. McIntyre referred to earlier. I was extremely happy with the way you handled the phone call and helped him relax. Thanks, job. So great teamwork between Brian and Carla. They even exchanged a little affect for each other in the email that I didn't put in. They worked together for a long time, so they have a close personal relationship. So the patient was active with us from January 19th to March 2nd. Pretty extensive episode of care, right? Received 24 total home care visits, 9 nursing, 7 PT, 6 OT, high therapy utilization therapists, and 2 social work. Highly satisfied with our care. No care. And what's motivating? No hospitalization. Okay? So COPD, heart failure, patient would go to the emergency room when we intervene in a great teamwork type of effort. Telehealth was in there. This is a great situation. Great job by HCR. So Brian, Carla, congratulations to you. So let's briefly mention, what was really good about this case report? What did you learn? All together. Communication, Dr. McIntyre said that earlier, right? Prompt communication. I think the thing that I want to drive home is prompt action, right? If this patient's in anxiety state, he's not feeling well, and we on this, before the end, that guy was going to be in the emergency room, probably admitted to the hospital.
One of the points here, too, and we all kind of have to think about this as clinicians, and I was in the field, so I totally understand what it's like. The patient was not scheduled for Brian that day. He looked to use his clinical judgment of what can I move to get in here as the case manager, not I'm full today, nothing like that. It was, this is my patient, I want to keep them at home, and he acted. So that's something I think that we need to take ownership and investment in these patients of doing something that might be an inconvenience to you, but think of what it meant for this patient, right? Avoided the emergency room. He's a sick man. He probably would have been admitted, but we kept him home by just making some adjustments and doing what we're really, this is our duty. This is why we do this. This is home care. So great job, guys.
Right on time, which was my goal. So I thank everyone for attending. I really appreciate it. We had great turnout, great interaction. We hope to bring more education opportunities like this to you in the future. Have a good day.